after we conclude the first case, I will discuss the second and third cases as well and probably have the discussion together in the end if that's okay. So the second case, we have a term baby born to a gravida 4 para 3 mother by elective cesarean. These parents were of Pakistani origin and gestational diabetes is well controlled. The parents are first cousins as well. The baby was well grown, 3.8 kilos, and was transferred to the NICU after the delivery, again thinking of transient tachypnea. The baby was started on CPAP, and because of the high oxygen requirements and increasing work of breathing, we changed to NIPPV, which is a non-invasive form of ventilation. And baby responded well to that. The chest X-ray was suggestive of transient tachypnea. The blood gases showed initial respiratory acidosis, which improved. As the normal protocol in our unit, we gave ampicillin gentamicin for 48 hours and discontinued as the blood culture was negative and CRP normal. Even though the baby continued to be symptomatic, we didn't continue the antibiotics, which is the right practice. Baby was started on tube feeds and weaned off IV fluids. Baby stayed on NIPPV and attempts to wean was not successful. So normally we would expect TTN to improve by 3 to 5 days at least, even in the severe cases. So if it extends to continue that, we start thinking about alternative causes. So there was no evidence of infection and the secretions were not significant as well. We had an informal discussion with the parents because parents often start getting agitated when the baby doesn't improve as they expect. In Dubai, we have insurance, and so the cost of the treatment is not a huge issue. But I know in India, the cost also starts escalating, and that leads to the parents getting more agitated as well. So we said whether there was any underlying cause like cystic fibrosis. At that time, the mother mentioned that the baby's sibling, who was 10 years old at that time, he gets recurrent sinusitis and has a heart disease. And then when I probed, they said he has a dextrocardia with the VSD. So immediately I thought it could be a primary ciliary dyskinesia causing this persistent distress in the baby, as it has been well reported that prolonged TTN-like picture could be related to PCD. So the baby was started on regular saline nebulizations. I told the parents this possibility and they calmed down significantly. I just told them it needs another week or two to recover and we will work up for this. But at the same time, you don't need to panic because it's persisting. So the parents were trained in suctioning and nebulization and so on so that we could discharge the baby at the earliest possible. So the baby weaned off the NIPPV to CPAP and then over 2 weeks weaned off the CPAP, established suck feeding and discharged home. Even though we were prepared for recurrent infections and so on, this baby had a relatively stable course. First few months, there was some viral infections, but apart from that, nothing major. The ENT review was done and we sent a nasal mucosal biopsy to confirm primary ciliary dyskinesia. It was sent to US, lab in US in the appropriate material. The test was done around 2 weeks just before discharge, and it took another 2 weeks for the result, which confirmed primary ciliary dyskinesia. And the older sibling obviously has Carter-Jenner syndrome, and both are in the same spectrum. So as I said, the baby was growing well and just given the training to the parents, and this baby did well. I mean, now the child is around 5 years old. We counsel the parents about avoiding consanguinity in the family, which is very common in the Pakistani families. So primary ciliary dyskinesia is a rare problem. The incidence is 1 in 16 to 20,000 deliveries. The presentation is either in the neonatal period with persistent distress. This is not the common presentation, but as a neonatologist, when we see such cases, always keep that in the background and look for family history or other features in the child. And the baby may present later on with recurrent respiratory and sinus infections. There can be associated dextrocardia and situs inversus in 40 to 50%. Bronchiectasis, sinusitis, infertility are the associated findings. And 6 to 12% have heterotaxy syndromes with asplenia, polysplenia, and Ivermerk syndrome. Life expectancy is good usually with supportive treatment and timely antibiotic treatments. In the severe cases, because of the risk of bronchiectasis, you need to choose the right antibiotics, almost like you manage cystic fibrosis cases. So it was initially described as immotile cilia syndrome, but then the study showed that the cilia were motile, but they exhibited a stiff, uncoordinated or ineffective beat. Then the name was changed into primary ciliary dyskinesia or dysmotility. So there may also be secondary ciliary defects when there are multiple causes of epithelial injury. For example, smoking is an important factor and working in polluted environments can affect your ciliary function as well. The cilia and flagella evolutionary ancient organelles. So even in the protozoal species, you would see the amoeba has a single cilia at the top. The structure and function is rigidly conserved across the phylogenetic spectrum. They have a role in cell motility as well as transport of fluids over the mucosal surfaces. They also have a sensory function that modulates elements of the development and cell functions. For example, we have cilia in the renal tubules and so on as well. Both the motile and sensory cilia are composed of highly organized arrays of microtubules and their accessory elements. So this is the structure of cilia in the respiratory epithelium. So we have the microtubules, 9 pairs outside and 2 microtubules in the center. And we have the dynenorms, the outer dynenorm and the inner dynenorm, which are responsible for the direction of movement. So the Nexin link connects the outer microtubules, while we have the radial spoke, which connects the central with the peripheral microtubule. So the ones that are beating back and forth will have this structure, while the ones which have rotatory movement or non-motile ones do not have the central microtubule structure. So you have basically the motile cilia, which is the planar motion one. Mostly they're on the epithelial cells, the brain ependymal cells, the respiratory airway epithelium, reproductive tract, and also the sperm. And in the embryo, we have the nodal cilium, and that's why we have the asplenia, polysplenia, malrotation, and so on. So when we have embryonal development and the axis of development changes in the organs, it's mainly because of these. And that's why dextrocardia is one of the associations with ciliary dyskinesias. And we have the non-motile cilia in the kidney, tubule, bile duct, pancreatic duct as well, eyes where it is connected to the photoreceptor. So there is an association with retinitis pigmentosa-like symptoms. And in the ear as well, the kinocilium is having ciliary motility. So you can see here, this is the normal one. And here the both arms are absent, and different variations of the dynenorm absence. And here we have a small video showing you the normal ciliary motility, back and forth movements, very organized, coordinated, and you can see how effective our ciliary motility helps to function. And we have the rotary, irregular, incoordinate movements in primary ciliary dyskinesia. So it's not going to be in one pattern, and you can see different areas are moving in different patterns. So this becomes incoordinated, and it's not going to be really helpful to clear the secretions. So the gold standard is electron microscopy of the ultrastructural biopsy from nasal scraping or bronchial brush biopsy. There are genetic tests available as well. I'm sure we will have this panel developed soon. And nitric oxide measurement on the nasal mucosa is tested. Nasal nitric oxide is very low. It's 10 to 20% of normal in patients with PCD. So again, this test is not routinely available, but in the referral units where we face such cases frequently, you might see that. The clinical features include different organs as we discussed. So the middle ear is affected, chronic otitis media, hearing loss, and the paranasal sinuses, nasal polyposis can be seen. Sinusitis is common. And in the lung, we have the prolonged neonatal respiratory distress. This is not severe, but prolonged. And we have the recurrent pneumonia, bronchiectasis as well. In the genitourinary tract, male mainly, but possibly female infertility as well. And the situs inversus heterotaxis syndromes due to the embryonal model that we discussed.
Sorry to interfere, Sridhar sir.
Yes.
Many people are.
Sorry?
You're mute, sir. You're mute.
Sir, continue, sir, please.
No, many people were saying what?
Well, voice loud, a bit louder they want, sir. They want.
Yeah, sure. Thank you.
Thank you.
So in the eyes, you can have retinitis pigmentosa, as I mentioned, related to the. So the situs inversus totalis occurs in approximately 50% of patients with primary ciliary dyskinesia, and we said 6 to 12% might have right isomerism, IV mark, and polysplenium as well. The chronic wet cough needing a recurrent antibiotic therapy in a child should also prompt testing for PCD if you have suspicion. Cystic fibrosis also would be looked at if you have a family history. So you look for all these features and they're present, you have index of suspicion. So I mentioned a neonatal case, but many of your pediatricians, you might be seeing recurrent cough, wheeze, and chest infections. You may have to think about it. It's not that rare, though it's not that common as well. So we have a cilia expert as well. So hopefully she'll comment on how she sees in practice. So the life expectancy is good in such cases with supportive management and timely antibiotic therapy and preventing bronchiectasis. So timely use of antibiotics, saline nebulization could help. Ventilation in the room the child is in, avoiding pollution as well, if possible. And obviously, if bronchiectasis does develop, they need expert management with the pulmonology team.